Welcome everyone to June in North East London Health Scrutiny Commission. We're here at Hackney Town Hall. We have a quorum of members present in the chamber. That's councillors Chowdjury, Adams, Masters, Salvant, McMallan, Ali and Hudson. And we're joined remotely by other colleagues, including Councillor Zammit, Councillor Snell and Councillor Sweden. I don't think I've missed anyone else off. We're being live streamed, recorded. Members of the press will be watching. Can I ask those online to please keep your microphones on mute when you're not speaking? Please keep your cameras on. Please do not use the chat function. Please raise your hand to get my attention online. Can I welcome, please, Councillor Adams to the committee, and welcome back Councillor Masters from Newham, and I've got an apology from Councillor Ahmed. With those matters of housekeeping, I can then move to declarations of interest. I haven't been notified of any. Councillor Masters.
In the interest of transparency, although we are scrutinising the whole North East London system, I'm currently working in my day job in a role in the voluntary sector funded by Hackney CCG.
Thank you. And can we note that for every meeting going forward? So sort of to save, if we need to, the continual repetition of it. Then with that, I'm going to move to the first substantive item on the agenda, which is item 3, challenges of building back elective care. We've got Henry Black here, the acting accountable officer. We've got Tracey Fletcher from the Homerton, Alwen Williams from Barts, and Stephen Edmonson, who's the chief of surgery at Barts. I've got 20 minutes for this item. I understand Henry's just going to give a very brief overview, followed by Tracey, Alwen, and then Stephen. If we can keep the presentation to about 5 to 6 minutes, if possible, 7 at max, then I can open it up for questions. So, Henry, over to you, please.
Thank you very much, Councillor Hayhurst. And as you say, I will keep this very, very brief. For those who don't know me, I'm Henry Black. I'm the acting accountable officer for North East London CCG and the SRO for the integrated care system. So as our colleagues will, I'm sure, be aware, North East London was hit very hard by the COVID, particularly the second wave. And as a result, we were forced to country as a result of being hit harder by the second wave. This meant that we were already starting from a difficult position in terms of elective backlog, but it meant that scaling back that elective care work happened quicker, and therefore the backlog grew even more. So the kind of context in which Tracey and Alwen and Steve will present the current plan for recovering that elective care is that we were probably in the most challenged position in the capital, if not in the country, in terms of the size of the backlog and the weight of the challenge that we had. So that's just a little bit of context for the group. And on that note, I will hand over first to Tracey, who will then hand over to Alwen in due course.
Thank you, Tracey.
Thank you, Henry. So I'll just give a very brief overview of the Homerton and a little bit of reflection on how we're working together. So, I mean, Henry's outlined the background of this. We as an organisation have got both our elective operating services and our outpatient services, and indeed the diagnostic services back up and running. Our performance is not yet at 100% of what it would have been pre-COVID, but it's around the sort of mid-80s mark. So it's.
What does that mean, Tracey? Mid-80s of what? 80%.
About 85% of what we would have been doing pre-COVID in terms of levels of activity, which, given that some of the ongoing PPE requirements and therefore the slightly slowing down of the theatre list. That's a reasonable level of throughput. We, like all other organisations, build up our waiting list over the course of the pandemic waves, when inevitably elective care or elective treatment was stepped down, partly because particularly in the first wave, the separation between red and green, so i.e. Isolating areas in which you could maintain infection-free zones, but probably more importantly in the second wave, just the sheer the sheer activity levels, which then led to lots of staff being redeployed again into intensive care and the ward areas, reducing our ability to run theatres. I guess one of the changes that we have seen, particularly within outpatients and over the course of the last year and a half, and this continues into the recovery period, is a balancing off between face-to-face appointments and telephone or this sort of technology appointments using video conferencing with patients, and we're still maintaining a fairly significant amount of both telephone and virtual appointments. That's in line with, I think, quite a lot of direction of travel where that is possible and can be a better service for patients. But we've equally at the same time stepped up a reasonable amount of face-to-face appointments as well.
Tracey, I've just got about 3 minutes left before I want to go to questions. So is it all right if I cut you off there and move on to Alwen?
Sure.
Thank you. Alwen?
Thanks, Ben. Just really, I think the story at Barts is very similar to that which Tracey has described for the Homerton. Just to really, I think, statement to the obvious, clearly the backlog issues and the size of the backlog reductions required at Barts are very significant compared to the Homerton. We have restored elective services in the same way as Tracey has described. We're also having to ensure that we've got the elective capacity to do our most clinically urgent cases, so what we call our P1 and 2s, and about 50% of our elective capacity has to be dedicated to those very urgent life-saving cases as well. And as you will appreciate, we're also managing non-elective demand that's increased as well as lockdown measures are lifted. And as Tracey says, clearly also having to bear in mind the health and well-being of our staff, and obviously now planning for a potential third wave in terms of any impact of that. So this is it's a bit like walking a tightrope, really, in terms of being able to predict what might go forward. I'm very confident at Barts that, you know, we're working really well across North East London. Steve, in the few minutes we've got, it might be best to bring Steve in to talk about the high volume, low complexity hubs, which are really a huge potential to ensure that we can really treat patients as quickly as possible. Looking at mutual aid, I know 300 patients have already gone from Barts to the Homerton, looking at IS capacity, looking at developing our own capacity in-house. So, for example, at the Royal London, we're opening new procedure rooms for paediatric dentistry, which is a large chunk of some of the very long waiters. And that's going to be a London facility, not just a Royal London Hospital facility. And very similar story in terms of outpatients, really, in terms of percentage of workload that's now being done virtually. I know you're pressed for time. Can I bring Steve in maybe just about the joint work? Thank you.
Thanks, Alwen. Good evening, everyone. So just specifically on the high volume, low complexity hubs, we're doing this as an ICS in conjunction with BHRUT and the Homerton. This has been led by NHS London. They have designated 6 big specialties, which carries about just over between 50 and 60% of our high volume, low complexity work. Those 6 specialties are orthopedics, ophthalmology, ENT, urology, general surgery, and gynecology. And currently the HVLC hubs are split, having 6 of them delivering all 6 specialties at King George's Hospital, Ilford, and between ourselves and the Homerton, another 6 hubs, which are some are actually established, some in development. So within Barts Health, we have ophthalmology at the Eye Centre at Whipps Cross, ENT and urology in the Plaintree Centre, also at Whipps Cross, orthopaedics in the Gateway Centre at Newham, and gynecology and general surgeries have been delivered at the Homerton. I think the only other thing I'd just say is we're making good progress with those HVLC hubs, with enormous backlog of patients because of the impact of COVID. But throughout all of this, we have continued to treat our very urgent patients with life-threatening conditions right through the eye of the pandemic, both in wave 1 and wave 2.
Thank you very much, Stephen. I mean, I maybe got some questions in a minute, but first of all, can I go to members who may have questions? Cllr Adams.
Yes, my question is about staff morale. I'm just wondering, what are the plans to motivate your staff in carrying out this difficult task?
Okay, I'll take questions in groups to save time. I've got Cllr Masters.
In terms of the urgent life-saving cases you're referring to, how long do you think it will take to get back to a kind of normal level, and what are your targets for addressing this?
And Cllr Chowdjury.
Thank you. My main concern is about staffing. Do you have enough member of staff to make sure that you are able to clear the backlog?
Okay, so those 3 questions, 2 related to staff, 1 in terms of targets and the life-saving. Who wants to pick those up?
I can deal with the emergency surgery question if you'd like, then.
Yes, please.
So the answer is we have restored emergency surgery right across the trust. In terms of life-saving, we have a prioritisation process. P1 would be the patients who need very urgent emergency surgery within 24 to 72 hours. All those patients now have been dealt with within our own footprint through our emergency departments and emergency surgery. So of our 51 theatres across Barts Health, we have 17 at the moment dedicated to emergency surgery. In terms of urgent cancer work, we still have some gynecology oncology being delivered in the independent sector, so we've not been able to repatriate it because of the pressure of our own elective programme and the amount of trauma and non-elective work that we're seeing, which is increasing steadily to sort of unprecedented levels. But generally speaking, the emergency treatment never really stopped, and it is now back effectively to normal.
Just out of interest on the cancer pathway, so where are we at in terms of, obviously there used to be, there probably still are enforced, the targets of so many weeks to first referral, to diagnostics, to treatment, to end of it. How far are those timescales now out?
So we're compliant with our cancer targets generally. In terms of actual surgery, as I would come back to those P categorizations 1 to 4, just for council members to clarify, P1 is needing emergency surgery 24 to 72 hours. P2 is surgery within a month. P3 is surgery within 3 months. And P4 means the patient can wait without harm for longer than 3 months. We are meeting all our P2, and that's where the cancer patients are very largely sit there. They're needing their surgery within a month, and we refer to clearance rates or clearance time. So you have a projection of your capacity and the amount of surgery you can offer. And we've now got clearance times down to less than 4 weeks in all our urgent categories, including all our cancer.
Thank you. That's helpful to know where most cancer sits. Alwen, can I go to you on the staff?
Yeah, sorry, just to quickly add on the cancer, and we can get this data to you, but actually we're very proud that North East London is actually best in class in the whole country for 4 tumour types in terms of the 60-day urgent suspected cancer referral target. So we've done exceedingly well in North East London when you think of the scale of the impact of COVID. I would say in terms of staff morale, I think staff are tired. It's very true. There's no denying NHS staff have been through the mill in the last over 12 months or so. That said, we cannot fault commitment to patients and dedication to each other. So, people are tired. We are making sure that we constantly support staff in terms of their health and well-being, in terms of their risk assessment, supporting staff in terms of vaccination rates, and ensuring that they have the support, psychological support, health and wellbeing support, which is very well received. To the question about staffing, the simple answer is we don't have enough staff because we've got an enormous backlog because of the curtailment of elective work, and that's why it's going to take some time before we are able to clear that backlog, because our constraint is going to be the activity that we're able to do, not just through the resources at our disposal in terms of theatres and estate, but principally about the allocation of staff to the work.
Yes, so even if you had enough resource, even if you had enough, say, theatre capacity, and you had enough money, you just haven't got enough bank staff or to call upon to actually get to the list quicker. Is that the main constraint?
Yeah, and this is the case for the whole NHS. It's not just East London, because we're all more or less in the same position. We've all got the same challenges. So that's the rate limiting factor. And we will get. I mean, at Barts we've already reduced our backlog by about 5,000 patients overall in the last 3 months. So we're doing really well, and that's partly because we're really targeting the activity that we do to what Steve's described as the P1s and P2s, and then really to those patients that waited the longest. So we're doing this as methodically as we can to make sure those long waiting patients are seen as quickly as possible.
Thank you. I've got Councillor Sweden who's raised his hand online. Richard.
Alwen's partially answered my question, but I'll just ask it in case she wants to give any more detail. I just wondered whether there was you were doing better in some disciplines rather than others, and emergency and life-saving surgery aside, are there any criteria for choosing to shorten waiting lists in one area rather than another? I'm talking about a clinical area, not a geographical area.
Okay, I've also got Councillor Hudson and Councillor Chowdhury again. Councillor Hudson.
Thank you. I've actually got two questions. The first, I want to follow up on what was said by Tracey and Alwen about the elective surgery running at about 80 to mid-80s% of your target. Presumably that means your waiting lists are increasing and that you need to be running at something like 120% in order to start getting them down. I just want a bit of clarification on that, because in the answer given to the last question was reference to waiting lists coming down. That presumably is you're looking at category 2 as far as I'm concerned. Presumably elective care, we're looking at category 4. My other one, I think, is to follow up partly on an answer to the previous question. To what extent are you using independent or private hospitals to provide you with additional accommodation, additional services, or is that out of question because of budgeting and costs?
And Councillor Chowdhury.
Actually, on the same line, follow up from the previous question, that if you have enough money, I'm sure you can expand on your staffing as well as resources. But then my question is that, do you have enough money? Is there enough funding? If not, what are you doing about it? Is there any possibility to be able to get additional funding to be able to resolve the issue?
Okay, I think I'll take that as the end questions here, because I then want to move on. So, Steve, do you want to maybe answer the one on the original one from Councillor Sweden on any other criteria for priority?
Well, I would point out there are certain areas we identify where we're particularly challenged, and where, if you look at our long waiters, patients who are waiting a long time, 60% of that resides in three areas. That's paediatric dentistry, ENT, and to a lesser extent gynecology. So we do have mitigations coming along to deal with that, but we accept that we do have a big challenge. But if you take, for example, paediatric dentistry, we now have Operation Tooth Fairy. We'll be having 3 operating rooms coming on stream at the Royal London. That's part of a regional initiative. It's not confined to Barts Health, but that should make a big difference to that. And we're having to, do initiatives where we've got kind of really challenge waiting lists. So we always have to prioritise those P2 and obviously P1 are emergencies. That's by definition prioritised, but we have to always prioritise our P2. But we're trying to balance our operating list, keeping pace with our P2s, but making sure we address our long waiters, patients who've particularly been waiting for more than a year, because that obviously is a big challenge, but something we didn't have pre-COVID. It's only happened effectively as a result of the loss of activity as a result of the 2 waves of COVID.
And so Councillor Hudson's point that if on Tracey's figures you're at, I know that's the Homerton, but 80 or 85%, then of course you're actually getting worse. Yeah, okay, we understand P1, P2, but because of the circumstances, actually P3 and P4 are actually increasing at the moment still.
Well, you then have to look at where those patients, where that's sitting. So we do have to separate then out what's called the admitted PTL, i.e. people on surgical waiting list or other waiting lists who have been seen and allocated for waiting lists, and patients on a non-admitted PTL have not yet been allocated or may not even have been seen. And those are very, very high volume of patients. We have a number of ways of trying to help those patients, so things like advice and guidance, triage. Or we may want to say more about that. There are a number of also community schemes that we're looking at. We've got one starting in ENT, for example, whereby we can help with patients who we frankly don't have the capacity to see at the moment because of our workforce challenges.
Thank you. And then, Alwen, if I can come to you for the final 2 parts, Councillor Hudson on the extent that we're using private capacity, and Councillor Chowdjury on additional funding if it's available, and then I'll wrap this up.
Yeah, I mean, yes, we are using IS capacity, and we will continue to use IS capacity because clearly that enables us to treat more patients in terms of the waiting list issue. I would say just very quickly back to the point Steve was covering, that we have to remember that when we talk about the overall list, as Steve says, a lot of that is the non-admitted, and there's a lot going on in what we call outpatients and non-admitted pathways. We won't have time to cover it all, but advice and guidance issue, it's about transforming, if you like, perhaps outdated practices of referrals in, creating a waiting list and really trying to work very differently, as well as the virtual, as well as looking at community pathways. So, you know, a lot of work going in terms of that transformation space. And our predictions at the moment don't assume that we can continue electives at least 80%, depending where we end up on the 3rd wave. But obviously, if that's those assumptions don't come according to what we're planning, obviously there might be more of an impact overall. But we're hoping that, and we've modelled in some further increase in GP referrals as well on a met need, that we might start to bring the overall waiting list down from about November, December time. So it is increasing. And we're continuing through all of these measures to continue to try and get that mid 80% up to over 90%. We're still waiting to see what happens, and indeed outpatients more than that. So our outpatient targets go over the 100% to do precisely what you're saying. We're also clearly waiting to see what happens post 19th of July in terms of infection control, because as Steve says, that's a very big constraint in terms of productivity and the extent to which that also some of those measures might get relaxed. So yes, on IS. And the issue is the money isn't the issue. The constraint again is workforce. So the way in which what's called the elective recovery fund is operating across the NHS effectively funds the elective, and we're being encouraged very strongly to do as much work as possible, because people just want us to get through the planned care recovery as quickly as possible. That isn't the constraint. It is the availability of workforce.
Thank you. Okay, with that, I'll wrap up that item. Thank you everyone for joining. Those who aren't presenting or involved in later items, please feel free to leave, and thank you very much for joining. I'm now going to move on to item 4, which is the implications for North East London of the white paper, which is currently going through Parliament, and I understand is due to receive royal assent in January 2022. We've got Henry Black, Mary Gabriel, who's the chair of Inner North East London Partnership, and again, Alwen Williams from Barts. Henry, do you want to kick off with reference to the presentation?
Yep, thank you, Councillor Hayhurst.
Henry, I thought it was me.
I'm sorry, Marie. Yeah, I'm trying to save your voice.
I lost my voice earlier, so he was putting off.
All right,
me.
Mary, over to you.
Thank you so much, Councillor Hayhurst. So there's 2 specific updates that we wanted to provide this evening. The first is from Henry, and it's in relation to the publication only last week, a week today, of the Ics Design Framework. And which seeks to provide more detail on the next stage of the ICS and expectations. And Henry will brief members on the key points, but it's quite a recent publication. And what we're doing, we're continuing our conversation. We've got quite a few booked in the next 2 weeks to think about how do we as a partnership, because integrated care systems are a partnership, best respond to the new framework. And the second update we wanted to bring this evening, which all will be leading on, is an update on the Acute Collaborative. We may recall from last time that we, as an integrated care system, asked our Acute Collaborative to think about how they can work together to address our challenges. And specifically, it is the access, the weights that we were talking about, both in terms of elective care, but also accident emergency services, how we can attract more clinicians into the area, how we can do more in terms of our borough-based partnership working to make sure we can effectively work as a system to recover our services, and how we can ensure that we do all this in a way that reduces health inequalities. So I'm going to hand over to Henry first, who's going to do the update on the framework, and then Alwen will pick up on the Acute.
Henry, if you could do it in 5 minutes if you can, and then Alwen hers in 5 minutes, and that leaves about 20 odd minutes for questions.
Absolutely, yes, Councillor Hayhurst. I'll try and be even quicker than that if I can. And well done to Marie for being able to speak. I know she's lost her voice. So the committee will have read various and been updated with various pieces of information. And as Marie says, the white paper was presented to Parliament in February and is going through that process. Since then, we've had various different pieces of guidance through from the Department of Health and Social Care and via NHS England in terms of operational implementation. The key points from the white paper around what the changes to legislation will result in and the implications it will have for the way the NHS and social care operates. The first point being the concept of an integrated care system, which is fundamentally to bring more closely together in a more formally constituted way health and social care into a genuine partnership that has formal legal accountability and governance around it. So that will comprise a number of different constituted elements. So the first is that the CCG will be abolished and a new ICS NHS body will be established. That body will take on most of the commissioning functions of the CCG, including the responsibility to hold the financial allocation, and it will perform most of those commissioning functions. And then the partnership will be governed through a broader partnership board, which will be expected to have members of the broader health and social care network. The ICS body will have a board, and it will comprise a number of key statutory posts. So a chief executive, a chief finance officer, a director of nursing, and a medical director, and various other posts. It will also be expected to have representatives from the providers and from primary care and from the local authority. That will be the core, the governing body of the ICS, the new ICS NHS body, and then the partnership board will be have a much broader remit and contain a much wider membership. So the guidance that's come out in the last week, as Marie says, it provides a bit more detail on how it's expected that will function. There's a bit more on some of the HR considerations and the expectations of the roles and what those roles will look like and will do. We are still, as Marie says, we're still in the process of discussing some of the details. And when it comes to the kind of key delegation or the key governance considerations, which are largely around delegation of powers from the ICS body to the other component parts of the ICS, those will need to wait until we've got clarity from the legislation, and once that has fully passed its way through the House. But essentially, the two key kind of partnership bodies within the NHS will be the provider collaboratives, but the founding kind of principle will be, or the kind of bedrock of the partnership will be the borough-based collaboratives, the borough-based partnerships. Those each borough area, or in the case of City and Hackney, the unitary function of the City of London Corporation and Hackney working together. There will be 7 borough partnerships in a similar footprint to the 7 CCGs that we used to have. But the key difference there will be that there will be formal partnerships of health and social care, and will bring other partners around the table. They will also clearly will have representation from all of our providers as well. But their key function will be to design and deliver a kind of wraparound health and social care service for a community around a kind of neighbourhood model. The borough-based partnerships are very much the cornerstone of the integration of health and social care, and the key delivery footprint for the new ICS. The legislation also gives consideration for what we're calling provider collaboratives. Each provider will be expected to operate within a collaborative, and the way that Steve described in the last session, and Alwen and Tracey, the way that the providers have been working through COVID is a very good indication of the kind of collaborative endeavour that we expect, and is we're already seeing our providers working together. So effectively working, sharing best practice, developing more kind of clearly worked clinical networks and clinical leadership across provider collaboratives, and giving the ICS a kind of a much more coherent vehicle in which the ICS can effectively set outcomes, and then give the providers the kind of the challenge and the requirement to deliver those outcomes in the best way that suits the kind of distribution of assets and workforce and other things that they can do. So that's a kind of brief overview of where we're at. As I say, still the guidance is still in kind of interim form. The legislation is still due to pass through Parliament, so things could still change. I expect what comes out at the end of the process to look slightly different from what it does now, because it always does. But that's effectively where we are now at this point in time.
Thank you, Henry. There'll be some questions on that, I'm sure. Can I go to Alwen first for that part of the presentation? Then I'll take the questions. So, Alwen, over to you in terms of the Acute partnership.
Okay, thank you. Yeah, I think that what we've seen, as Henry says, is a sea change really in terms of hospitals cooperating, trusts cooperating during COVID, because there was a compelling reason why we had to do that. And as you all know, the internal market sometimes didn't lend itself to hospitals working well together, given the kind of competition angle that was in situ. I think now we're moving towards integrated care. We've actually got some real building blocks of clinicians working really, really well together with that compelling purpose now of planned care recovery and anticipating any further COVID peaks. So what we want to do really is not turn the clock back. We have the opportunity to build on all of those joint relationships over the last 12 months. We're already working together in a partnership in terms of planned care recovery. We meet every other week. Our clinicians are working together to develop the hubs as Steve's described. In all of this, what we've recognised in North East London is there are those specific similarities really between Barts Health and BHRT in terms of perhaps what we could describe their challenges over the years in terms of quality and financial recovery. And equally, I think looking at the Barts journey in the last 5 years or so, some improvement really that's been brought about by the group model that basically has a group leadership team as well as hospital leadership teams working together, and will work even closer together in the new place-based partnerships within boroughs. So the where we've got to really is exploring the where we could further develop opportunities for stronger joint working, particularly between Barts and BHRT, because of some of those similarities in terms of history and opportunity, really, to maybe mirror some of the work that Barts has been doing in the group model across to BHRUT. And to that end, at the moment, we're undertaking a detailed appreciative inquiry process, really to build what I would call an initial set of propositions. I suspect those will be in situ by about the end of July. As you will be aware, both trusts agreed to appoint a chair in common, and that process is underway with interviews in July, and that's really very much to ensure that the boards become enablers of this collaboration across our clinical networks and across our services on a wider footprint. The key elements, really, I would say, is firstly to ensure that the collaborative working is very focused on improvement, and particularly on quality improvement and outcomes and equity, as Marie has described. So those are some of the key areas of focus for our appreciative inquiry. There are moves now to develop a much more stable leadership team at BHRUT. They currently have many interim executive directors, for example, starting to appoint substantively to provide stability of leadership, because we know that's really important in terms of delivering high quality care. And then looking very much at the operating model that the group has, Barts Group has, which combines both, as I say, a group leadership model which can take change forward at scale and at system where that's required, but also very strong hospital leadership teams that work in their boroughs and are operationally responsible for running their hospitals. So that's the overall proposition. It is very early days. I think the way this will proceed, as I described, there are various interviews going on at the moment with colleagues both out with the trusts in the ICS and within the organisations, and that will inform effectively what I would describe as an outline proposition in a month or so. But that will then continue to develop, and I think it will take us probably until the autumn to finalise that in terms of how we see a combination of all of those ingredients, if you like, that I've described, coming together to build a strong proposition for ongoing quality improvement and sustainability in terms of delivery of hospital services. And clearly a key test will be the delivery of elective planned care, urgent and emergency care, and also the way in which we've been working together in terms of the delivery of critical care services as well.
Thank you, Alwen. I've got Councillor Salva McMallan, and then I've got some questions.
I think it's wonderful to hear about the collaboration aspect, but I think there's a real worry or concern about the kind of top-down reorganisation which has happened at speed, it feels like, even though it's been floating around for such a long time during COVID. And I just really want to kind of make an appeal and also a question of patient voice within this process. Where will that sit, especially with the ICS and the partnership boards, and also scrutiny? Where will scrutiny sit so that we can evaluate this in the coming year?
And thank you. I've got Councillor Sweden who's raised a hand online.
One of my questions was about scrutiny, which has just been asked, and how both Alwen and Henry see themselves of engaging with individual boroughs in terms of their scrutiny. I can quite see how this, how you would engage with cross borough bodies such as this, and whether you thought that would be an ongoing responsibility. The other question is for Henry, I think, are you planning to have one administration for decisions relating to continuing care that will go throughout the whole integrated care system footprint, or would there be, as is now, would there be differences in emphasis in different localities? Thanks.
Thank you. And I suppose my question to Henry is that I appreciate there's a certain degree of flux depending on where the legislation and the regulations and notices sit when they come out of Parliament. But do you envisage that we'd be sort of maintaining the three systems approach we currently have, because there's reference there to 7 borough partnerships when we've been working on 3 models so far? And what practical changes do we see on the ground, or are we having to dance with the new legislation, but we carry on with, you know, some good work that we are doing already with those 3 systems that has got some elements of being very joined up? And to Alwen, I mean, at what point does it become too big? As I understand it, we'll be talking about 13 hospitals, if I've got that right. Is 20 too big? I mean, is it the case that because of the success that you have had with your leadership over, say, the last 4 to 5 years, that perhaps hasn't been replicated at BHRUT, you're being asked essentially to step in? But it wasn't long ago that Barts wasn't in that great a place. So what happens if in 5 years' time we don't have the level of leadership you're perhaps giving, and then we've got a much bigger provider in a much bigger problem? I mean, I'm still perplexed as to the drivers of this, other than the fact that essentially Barts has been seen to be successful in the last 5 years, and we want to pass that across to BHRUT. So I think patient voice and scrutiny. Mary, do you want to pick up on that, or Henry?
So, I'm happy to do patient voice. So this has been a really key area for us to develop, and we've been working in partnerships with the 8 health watches, but we've also been running a couple of workshops with a range of organisations and resident and patient engagement organisations. And that is really because we want to define in co-production what good participation looks like, and what's emerging is a set of principles that we can all share across integrated care system, but with a real focus of what patients and residents are telling us is we want a real focus of our participation in the design and transformation of services, which will happen at borough level, as well as having a voice at the ICS level. We're also doing that with voluntary community organisations who have a different role in terms of consultation and voice as well. And the third and final thing I'll say on that is about how we're working with health watches and around community insight, and they're providing additional information and helping shape our plans and decisions. I'm sorry about my voice. I'm going to hand over to Henry now.
Henry, do you want to pick up scrutiny first?
Yeah, I'll do scrutiny quite quickly, because our absolute expectation is that the scrutiny role will not change, and our interface with scrutiny will not change. I mean, it's not explicitly covered in the white paper, but there is an absolute expectation that will continue as it is now.
And in terms of Councillor Sweden's point about continuing care?
Yeah, I'll just pass over to Selina Douglas, who we have on the line, who is the SRO in North East London for CHC.
Yeah, absolutely. So continuing healthcare is a nationally mandated framework that we adhere to across all NHS CCGs as they were. Going into the single CCG, what we undertook was a review of all of our policies and procedures across all of our separate CCG organisations. And we're just currently in the process of looking at what the differences are across all of those policies and making sure we're in line with the national policy around continuing healthcare. There are some differences, but our aim is to deliver within the 28-day target, which is about making sure we deliver a continuing healthcare assessment within a certain target, and we do it in the right setting, so preferably within an individual's home. And so it's really important that we're doing those 2 elements. So to be frank, across North East London CCG, we will look at making sure we've got all the same policies and procedures. That's really important because it's a nationally mandated framework. I think, and then it's clearer for patients and for residents as well around what the expectations of continuing healthcare are for them as an individual. All of our continuing healthcare work has been part of the work we do with our Director of Adult Social Care, who we meet with on a monthly basis across all of our local authorities, and they are heavily involved in all of the conversations around continuing healthcare. Indeed, during the COVID pandemic, very, very quickly, just to say that in North East London, we dealt with our backlog, and we are now currently working with NHS England around what we want to do and what lessons learned we want to get out of the COVID period, including discharge to assess. So in answer, very quickly, in answer to your question, it's a nationally mandated framework. We're currently working on making sure we've got no gaps across North East London, and we anticipate delivering the 2 big targets that are around continuing healthcare as part of our performance management framework.
Thank you. And Henry, are we working towards maintaining the 3 systems if we can?
Yeah, as you described, Councillor Hayhurst, we have been working with those 3 systems for the last many number of years, and we've done that for reasons that have been kind of self-evident and have supported working at scale in a logical way. So where it still makes sense to do that, we will continue to do that. The white paper does take us in a slightly different direction, in that the borough-based partnerships become a more kind of defined focus, with more stuff happening with providers collaborating and operating at scale, which is intended to support that kind of clear partnership arrangement. So I'm not saying that we're going to abandon the 3 systems altogether, but it does. But the new kind of architecture that the white paper envisages does take us with a slightly more focus towards the 7 and the 1, if you like. So the 1 across NEL and the 7. But there's still going to be loads and loads of areas where it makes perfect sense for 2, 3, or even 4 boroughs to work more collaboratively. For example, in Newham and Barking and Dagenham, those are our 2 areas of highest growth. Barking and Dagenham doesn't have a site, so it makes, and most of the patients from Barking and Dagenham go to either Newham or to KGH. So that's an example of where 2 boroughs that don't necessarily sit within the 3 ICPs that we've worked at before will need to work more collaboratively together. The same is true of Waltham Forest and Redbridge. So there will continue to be lots of collaboration, but it may not be quite so precisely defined in the 3 subsystems that we have now, unless it makes sense where it specifically makes sense to do that. So we're trying to be flexible and as innovative as we can be, whilst maintaining those good links that we've established.
Okay, thank you. And Alwen?
So just to be clear about hospital numbers, so at the moment the Barts group covers 5 and the HLT covers 2.
Okay.
So that's the kind of proportionality. Just to be very, so it's just so just in terms of the model, I think the group model, I think does, and maybe we haven't got time this evening, but if helpful, I can explain this further in due course, really, how the group model works. But the group model effectively has group directors in a group leadership team, and has effectively at each hospital a hospital chief executive and a leadership team, as you would see in any other hospital. And we therefore get the best out of very capable hospital leadership teams running services and connecting to their boroughs with primary care, local government, etc. And the group layer very much in the realms of clinical transformation strategy with some overall accountability, and I can describe that a little bit more. That can bring benefit both in terms of doing things locally but also doing things at scale. What I would say is, if we weren't investigating this as an option of working through the collaboration agenda, the risk is that we might need another layer. And because the Barts group leadership team is in existence, actually understanding how that leadership team can work at a larger scale makes a lot of sense from a kind of economies of scale as well. I think, as Henry says as well, in terms of population growth, if we look at the group model in Barts, we're moving forward well with the redevelopment of Whipps Cross, and we're certainly at the forefront of the national programme in terms of redevelopment of Whipps Cross, brought about because of that strategic capability, if I can put it like that, within Barts Health. We're really going to need that given what Henry's just described. And if Barts and BHRT weren't working together, the risk would be that we would be clearly very focused on Newham, BHRT would be very focused on Barking, Dagenham and Havering and Redbridge. And actually, when you look where that population growth is, it's absolutely straddles those boroughs. So we've really got to work really differently to come up with the strategic responses from a hospital sector, working with partners in terms of that very significant strategic agenda ahead, as well as over the next year or so, clearly the COVID agenda in the way I've described it. So we are looking really of ways of effectively enhancing that collaboration. The two organisations will continue as separate boards, so you know this is going to be done in a very slow and steady way, ensuring that we're very clear about where we get the benefit of working across the group model, where there's benefit in having very strong, stable hospital leadership teams, as I described, and also really bringing into the fore the potential for stronger borough-based working. And that's then, you know, we'd be looking at that across the whole of North East London.
Well, I mean, the elephant in the room is, where does this leave the Homerton? I mean, because you could say many of the arguments you've outlined in terms of borough-based working, collaboration of acute trust would apply to the Homerton. I mean, you'd be met by a lot of political opposition if that was on the table. But the arguments you've said equally apply to the Homerton. So why not the Homerton?
Well, I think certainly there's been a discussion with the Homerton, and there's, as you say, Ben, there's, you know, the priorities really for now are really trying to make sure that we're able to address some of the key challenges. And the Homerton is, you know, a very good trust working well in its borough, and there's a lot we can learn from the Homerton, to be honest, and Hackney, and we'll want to do that. You know, if I look at partnerships, you know, they will be multiple. So when we look at planned care recovery, the partnership board that we have there includes the Homerton as much as BHRT and Barts. We have, as you know, a pathology partnership, including the Homerton, Barts, but not BHRUT. So there'll be different partnerships solving different issues really going forward. I think in terms of concern from Hackney and the Homerton, you know, what I would see is, as we get clarity on what the BHRT/Barts collaboration might entail, there'll be an equal and opposite collaboration agreement with Homerton and Hackney. So we're very clear, really, where that collaboration sits, and that collaboration has to be to the mutual benefit of the population and, you know, the patients that we serve, and that's going to be the driving force really for the partnerships that are set up.
Okay, thank you. Cllr Masters.
I'm going to roll back away to the question about scrutiny, because I'm really interested in who it would be attending scrutiny. Because and I haven't had the opportunity to look at the design framework, which I really hope will be shared with us after the meeting. But in the white paper, the buck stops very firmly at system level. Does this mean that it would be the system level leads that would be attending our scrutiny in all our boroughs? And then secondly, I'm just wondering how you're feeling about the sort of added pressures in terms of sort of meeting financial targets, and whether you're confident that you'll be able to do that.
And I've got Councillor Hudson as well.
Thank you, Chair. I'd like to follow up on the question of scrutiny as well, because I noticed there's nothing in the paper about it and nothing in Officer's presentation. Now, Officer's been talking about a white paper, but if we're talking about legislation, then presumably there is a bill before Parliament. As I understand it, scrutiny committees are a statutory requirement at the moment, and that they're there. What concerns me is that scrutiny committees are not actually abolished by a side wind, because they're simply not in there. And my question is, do we need to be making political representations to our members of Parliament to make sure that that doesn't happen?
Henry, do you want to go on back on scrutiny? Go on, Helen.
Well, I mean, really, just simply to say that there is no, there's nothing in the white paper that says that there will be a change, and our expectation is that it will continue to proceed as now. If anything changes in that regard, we will obviously we'll continue that dialogue. But in terms of who will, I think there was a question about who will come, and it will continue to be the chief executives of the statutory bodies, because the ICS will be established as a new statutory body, but the providers will continue to retain their own statutory status. So each statutory body will have a legal requirement to attend, and that's how we will continue to do it. So to all intents and purposes, there will be, in terms of scrutiny, there won't really be any change.
So just to be clear, I mean, obviously the ICS level, that's fairly obvious. It would continue pretty much as we're here right now. But then on the borough-based level, as I understand you saying, there is a requirement that, say, there be a borough-based lead, and that then that person would attend and be, what used to be, say, your David Mayer, or what is your Tracey and Hackney, doing those representations. And just for members, I think the current scrutiny is under the local government legislation. So I suppose you could actually say the fact that there's nothing in the current white paper that impacts upon scrutiny is actually a good thing, which means that the existing legislation carries on. So in essence, that's probably could be said to be as it were. In terms of the second point, I think from Cllr Masters' question in terms of finance, where are we also with what was the 80-20 principle, and also Cllr Masters' question in terms of how financing will work?
Okay, so in terms of the 80-20, I mean, we are still working through the next level for the ICS in terms of delegation. So the 80-20 was the principle that we are still retaining, but it was specifically in relation to the CCG merger, so how we will run operations from 7 CCGs to 1. Now we are immediately jumping through a second legislative hoop around from one CCG to ICS. We will still retain that principle, but it does mean that we will have to go through a second iteration when the precise guidance comes out about what a running cost allowance looks like for a new ICS. We haven't had that confirmed yet, but that principle of subsidiarity is still very much the one that we're using. In terms of more broadly, I don't think we can be under any illusions that, as it stands now, under the emergency legislation, the NHS has been given a settlement which is sufficient to do what we needed to do to meet the pandemic requirements. But the broader economic impact of COVID means that we will expect that to become very much more constrained in the future. Just for full visibility, we only actually have a settlement for this financial year that takes us to the end of September. We don't actually yet know what our settlement is for the second half of the year from October to March. So that kind of gives a bit of an indication as to the timelines and the horizons that the Treasury is able to operate within. We are receiving kind of soft intelligence that suggests that that the second half of the year will be similar to the first half of the year. But beyond that, when it comes to the next financial year and beyond, we do expect there to be across the whole gamut of public spending a new revised settlement that will come out in the spending review as and when the pandemic we come out of the other end of the pandemic effectively.
I've got Mary's hands raised. Now I'll go to Cllr Masters.
Just to say that the wonderful Marie Price has just advised me that scrutiny does remain as it is. So the design framework, which we will circulate after this meeting on page 38, actually is really clear that scrutiny remains as it is.
Yeah. Just before I'll bring in Cllr Masters, then I'll sort of follow up on my financial question with Henry.
Okay, it's just another financial question, actually. Talking about money made me remember that there's a very strange mention of the Better Care Fund and a change of that. And obviously that's a big part of our social care spending. I'm just wondering if Henry could explain the change in the way that the Better Care Fund will be dealt with and how that might impact on us as local authorities.
Sorry, Councillor.
Well, I was just going to say, just to sort of finish up, so we can wrap up this item. I mean, just on the future funding, though, because I mean, it's fairly clear how the three systems get their funding at the moment under the 80-20 principle, because you're just working on essentially passporting through what was previously allocated to them, apart from the top slice. That's fine. But of course, when it comes, say, to a new financial arrangement whereby, say, the new ICS is just given a pot of money, then what's the work through as to what, because obviously there's a tension possibly between boroughs that have a more demographic weighting of need versus those that have a more elderly weighting of need, and how that's worked through. And I know there have been previous debates. What are you going to try and keep something akin to the current formula within the 7 base? What's the thinking there?
Yeah, so the commitment that we made when merging the 7 CCGs is that we would we had a funding settlement that took the previous CCGs to, I think, 2025, and was specified by borough. So we said that the borough-based partnerships, or the local partnerships, that as we call them then, we would maintain that principle, and we would effectively create a formula that tracked that previous allocation. We don't expect to do anything different from that, but that would be in terms of a ring-fenced allocation for a defined population. In terms of the precise way that contracting will work in the new ICS, that is still slightly vague and not clear from the legislation yet, but that will emerge. So the way in which that money might be administered might change, but it would still be ring fenced for that particular population. So the borough-based partnerships
up to 2025.
Yeah.
Fine. Okay. And then Councillor Masters' question on the Better Care Fund.
I have to confess, I'm not sure what the reference is. I wasn't aware that there was a specific change to the BCF, unless Selina's going to rescue me.
Yeah, so I suppose there's a couple of changes, but not anything that we've worked out yet. The first one is around the way in which the BCF and the Section 75s are done across North East London in terms of the single CCG for this year. And so that relationship moves from a borough to a single CCG piece of work. So that's a conversation that's been had with all the local authority partners. And then the second thing is then how does that work under the new ICS framework? And at this moment in time, we're working out what those finances look like. What we've not been notified about, Councillor Masters, is if there is going to be any changes to the minimum percentages that we have to put into the Better Care Fund. And you will know already across North East London, we've got a variety of Better Care Funds ranging from tens of millions of pounds to hundreds of millions of pounds in inner North East London alone. And at this moment in time, we do meet all of our minimum requirements in terms of allocations into that BCF, and we're usually over and above. So at this moment in time, we're waiting for guidance in terms of what that would look like if we needed to change any of that or the allocations that were associated to that. Having spoken to our Director of Adult Social Care, one of their big things around this is things like the Hospital Discharge Fund, which we're using at the moment, which also includes elements of discharge to assess funding. And whether that's going to be wrapped up into the Better Care Fund going forward. But at this moment in time, I haven't seen the clarity around what those finances are going to look like, but I'm more than happy to bring that back once we've got some more guidance.
Thank you. With that, because we are just a few minutes over, I'm going to wrap up this item. I think it's certainly something on both fronts. I think perhaps maybe as separate items next time we'll want to keep a watchful eye on, perhaps at the right point in terms of when the planning's being done for the acute collaboration, and then come back where there's more detail there, and certainly whether it be at the next meeting or one in 6 months' time, to understand where we are with more granular detail in terms of the impact of the ICS and how it's going to pan out. So thanks for the update there from everyone involved. I'm now going to move on to the item number 5 on the COVID vaccinations. We've got a helpful presentation. We've got Henry again, Simon, who's the Director of Transformation, and Selina. I saw Henry was at the Olympic Stadium with Bimini, have I got that right? Bimini. Bimini, thank you. At the weekend, one of the mass vaccinations events. So who's leading on this? We've got 20 minutes for this.
We'll go straight to Simon.
Thanks, Simon.
Hi there. Yeah, and thank you everyone who turned up. We had 2 of our elected mayors there as well, which was really great. So first of all, what an amazing programme this is, but my goodness, everyone involved in it is really working flat out, as a lot of people on this call will know. At the moment, our numbers are standing something like having done 1,652,000 vaccinations, probably a few more since this data shot was taken. and in fact over 1,030,000 people have now received a vaccine at all. So that's the number we're looking at, pretty substantial numbers, and that's probably our best vaccination. It is our best vaccination program ever. Now we really are in the latter stages of the program, and we still have two key tasks. Firstly, we remain committed to prioritising those in the most vulnerable groups who either haven't had one dose or haven't yet had both doses. And there are some key targeted interventions we're doing for those at the moment. And secondly, we are targeting all adults now for the first dose and trying to get as many of those done as possible. Now, we have a particular challenge in North East London, particularly in North East London, in that our population, compared to the rest of the country, is intrinsically much younger, as you will all know. So we were always going to have quite a hard task because our numbers are weighted a lot towards the end of the national programme. But we are where we are with it, and we are doing our best at the moment. So we've, as you will know, a multifaceted approach. Particularly at the start of the programme, we had huge involvement from our GP providers, standing up lots of sites. They've continued and done the lion's share, actually, of the vaccination programme locally. As the programme has moved into these younger groups, though, we've stood up many more community pharmacies. We continue to do those as people have fed back to us that they like to have the vaccination much more close to where they are. So we're trying our best to have as many as we can of those. They're commissioned nationally, so we have to do a bit of persuasion to get them, but we've done reasonably well on those. And of course, we've got some big vaccination centres as well. Starting off at the ExCeL, which is now moving to be a second site at Westfield. The Westfield site run by East London Foundation Trust, and of course the sites at Chingford, Romford and Dagenham. In addition to that, now we're trying to do some big mass events to particularly attract younger people. You referred to the event at the London Stadium on Saturday, which was quite an amazing experience, which had two aims. Firstly, we vaccinated just under 7,000 people, but also we were able to really promote vaccination in North East London and target those people. And all the people in the queues I spoke to were from North East London, and actually particularly the neighbouring boroughs, the boroughs around the Olympic Park, which was fantastic, and they're the boroughs we need to target. We're now working very closely with our local borough teams and trying to ensure that we have pop-ups and walk-ins in wherever we can that's appropriate to do sort of more hyper-local events. We're looking at where local authorities are fabulous and have run call centres, helping to encourage people to come in. That's still happening, particularly with a focus now on the second doses. Lots of door knocking has been happening across the piece, linked as well to surge testing. And there's a range of different booking options. So we also have publicity on each of these events. We're trying to have a central place where people can go and just see and find a way that they can get vaccinated that suits them. So it's one of those kind of programs that we're trying to have lots of different sizes fit the multiple population of with varying needs across North East London. But there are challenges. We've had supply challenges. It has been what I would say it's been lumpy in terms of supply, and that continues. We have at the moment a level of people being a bit hesitant in terms of getting their second doses, particularly around AstraZeneca. And it is harder to get some of our communities in, and there is a higher level of vaccine hesitancy amongst some of them. Although we are doing really good targeted events using community groups, local faith groups, you name it, we're trying to find ways of trying to target those individuals. And we found that if we offer up some of our clinicians to have some of those one-to-one conversations, actually most people at the end of the day decide that they'd rather opt for a vaccine. I'll stop there because I know you've got questions, and I'll do my best to answer questions. And Henry and others are around as well.
Thank you. So first of all, virtually I've got Councillor Snell, then I've got Councillor Chowdhury, and I think Councillor Ali as well. So Councillor Snell, to start, please.
Thank you. It's questions about the detail of the report. I must admit, when I saw what I have as page 52, listing vaccinations by all sites, I couldn't understand why so many sites were missing, but I realise it's a snapshot rather than a full list. And it would be good perhaps after this meeting if you could circulate a link so we get a full list of all the sites. It's very interesting locally to know which ones are doing best, and perhaps direct people to them and give them more support. The bigger issue, so I realise that's just a presentational issue, the bigger issue, and tell me if I've missed it, is that in the report that we had to health scrutiny in Hackney, the worrying figure, and I've worried about this from the very beginning of the vaccine programme, the worrying figure is the low number of people who are in domiciliary care outside of care homes who have had their second dose. I mean, I think it was less than 10%. It was absolutely appalling. And it's always worried me that family members with care roles, and particularly those 0 hours people who for various different clients, have not realised that they are as eligible as NHS staff and are simply not going in and getting their vaccines. So have I missed that figure? Because I can't see that figure here. And in particular, what are you doing to target that group? Because we've got every other split going, but you haven't split out domiciliary care in the independent sector.
No, thank you. Councillor Chowdhury, before we come in, Simon.
Thank you, Chair. So since cases in Newham increasing, I assume that other authorities like Hackney, farmers would be in the same position. I could not quite follow about supply of vaccine. It would be ideal if it was possible to clarify again if we have enough supply, or what are we doing to make sure that all over 18s are vaccinated. But in addition, I wanted to mention that some, I don't know if it is called rumor or whatever it calls, there are information going around that under 30 women in particular should not be given the vaccine. It can cause other issues. If you are aware of that, number one, if you are, what are you doing to make sure that people have the correct information, especially those people who are not getting correct information but following the incorrect information and denying to the vaccine? Thank you.
And Councillor Ali?
Thank you very much, Chair. My first question related to domiciliary care, which Councillor Snell has picked up on. The second question I wanted to ask is on the rollout of vaccination to homeless people. How are we targeting these kind of vulnerable people in order to be inoculated? Thank you, Chair.
Okay. Have you got all those, Simon?
Yeah, I think so. Shall I try and run through them in order?
Yeah,
and if
please
I get something,
I've got it.
Remind me, because I was writing very quickly, and also I'm slightly challenged with hearing sometimes, so there was an echo in the chamber, so I'm not sure I got everything, but I'll have a go. So firstly, to Councillor Snell, happy to provide data in terms of sites and so on. The numbers of sites and where they are changes, and one of the issues we have is that the system that collates all the data actually puts the data against the site that was in charge of delivery. But if it was a pop-up site, we can't necessarily separate that out. So there are quite a few caveats with the data. I wouldn't have quite designed the way the data is collected on the national system if it had been up to me with the benefit of hindsight. But I'm very happy to give you, and I can circulate further committee in terms of where things happen. And some sites have closed and some sites have opened, which also is an interesting feature there as well. The list of current sites is updated regularly on the North East Southern Health and Care Partnership website. It does change frequently, and also we are doing with all our local partners pop-ups and drop-ins and everything like that. So it's a very dynamic way of managing it. So the site list changes on a daily or several times daily basis. Also, each of the sites, depending on how they're set up, may well have a different booking system, which I have to say is a bit of a nightmare, but it's the best we can do because we've had to sort of retrofit everything. So the vaccine centres and the pharmacies are booked through a national booking system, and then the GP-run services, and some of the pop-ups are booked in a different way through local systems. So it just, sadly, we're comparing many different varieties of apples, but I'm very happy to let you have data. I'm also worried about domiciliary care, and it is very difficult to get an accurate figure on the number of domiciliary care workers that have been vaccinated. It's actually quite difficult to get an accurate figure on the number of social care workers overall, including domiciliary care workers that have been vaccinated. And we're working with all the directors of social care across London and nationally to try and ensure we get better data. With the NHS data, it has been easier because we have an electronic staff record and it's largely linked to that. So that is pretty accurate. But the main data in vaccinations all relates back to the GP record. There's also how we deal with unregistered as well. So that data is notoriously difficult to get. Whatever the number is, though, I can tell you it isn't as high as we wanted, as you know. So we're currently trying to work with, again, working with our local authorities, because actually you're the ones who have the relationships with those agencies, to go through the agencies who employ the domiciliary workers to enable them to get vaccinated, which includes, in most of our boroughs, actually ensuring that they get paid for the session when they go and get their vaccine, for example. But I am worried about second dose as well, and the first dose isn't high enough in those groups. So doing all we can, but hoping to get more suggestions. So secondly, I think there was a question about supply and what we're doing to ensure we get an adequate amount. I spend, it feels like half my day on supply. Sadly, supply is nationally dictated, but what we are able to do is to try and work with that and prioritise where we put it. We're currently doing a piece of work to prioritise supply to areas with the lowest vaccination rates where we can, but that also means we have to have pop-ups come at the appropriate place. So it's quite a logistical nightmare, but we have a new way of recording supply and a new way of transmitting that to the national team from this week. So hopefully that will be even more effective. But the national supply is a bit lumpy, and sometimes we don't have enough nationally compared to what we think we need. And we have an awful lot of people, as you'll know, still vaccinated in North East London. Vaccine myths, yes, there's tons of vaccine myths out there. And we've also had quite a lot of activity locally from anti-vax people. Certainly at the stadium at the weekend, we had a number of incidents involving anti-vax activists being abusive to staff and also people in the queue. They were dealt with, but that's been quite worrying. And a lot of myths are circulating online. Now, we can't do a huge amount with some of those, but where we find something, it's reported and we work to try and address those. There's also a campaign across London on promoting the vaccination in London that we're very involved in. And you'll see much more of that over the next few days, fronted particularly by Professor Kevin Fenton and others on a London basis. So that's on that. Homeless people. We've done quite a lot of work with all our homeless providers, service providers, and also through a number of our GP practices. We have particular GP practices in City and Hackney and in Tower Hamlets that have dedicated services for homeless, and we've been running vaccination clinics through them. We've also run a number of outreach clinics, well, a lot of outreach clinics, and we started doing vaccinating homeless populations sooner than anywhere else in London, because we decided that we'd locally define them as in a priority cohort. So we have done considerably more percentage-wise homeless people than a lot of other areas in the country, but the problem is quite acute in North East London. So
and Simon, on the homelessness, on terms of access, you're not asking for GP records or passports or anything like that. It's rock up, get it, and then you get a card so you can come back and get your second dose, even if they're not on the NHS system.
Absolutely so. Absolutely, yeah. We do that not just for homeless people. Actually, you name it, people can turn up and we find a way of getting them done. So anyone now over 18 can be done. We don't ask questions. At the weekend, for example, at the same time as we had the stadium event, there was an event at the Arts Pavilion in Tower Hamlets. where actually it was specifically geared to vaccinate people who didn't have an NHS number and could just rock up. And we had a lot of people do that. I think there were about 900 to 1,000 people turned up at that event. So yeah, very clearly. And with homeless people, what we've tried to do is to then run events and also work with the groups that work with them to ensure that we get their second dose. As what we've done.
Thanks. I've got about a minute left, and I've got two questions. So, Councillor Adams, quickly, please, if we can.
One just quickly on COVID antibodies. Do you have any figures on that or North East London?
COVID antibodies for North East London. Councillor Salva McCallum.
Yeah, mine was just to say I'm a councillor in Tower Hamlets, and I went past the Arts Pavilion, and actually the queue that was forming outside was very impressive. And I think really shows that people need to be able to access the vaccine without registering for their GP. There's obviously a huge need for that. So I wonder how much more of a drive there is. And on top of that, just very quickly, I know it's a short time, is asylum seekers. We have a huge number of asylum seekers that have turned up in the borough, over 400 just before Christmas. And I just wondered whether or not, there are specific areas that are addressing asylum seekers.
Thank you. And then, Simon, can I just come in at the end? I know Hackney, Tower Hamlets, some of the lowest vaccination rates in the country. The response to that is, yes, we've got some of the youngest population, and so it's catch up. But stripping out the age weighting, say in the sort of cohort numbers 1 to 6, what's the where do we sit proportionally pro rata to the rest of the country? Are we still at the bottom of the pile, say when you look at over 80s or over 60s, or are we sort of mid-ranking? So I just wanted to get some sort of gauge once we strip out the low demographics.
Okay, I'll do those in reverse order. So the stripping out the local demographics, we're actually not bad for the over 80s and care home residents. We're, in fact, I think we've got the highest proportion of care home residents that have been vaccinated in London, which is very good. But as you go down into the 70s and 60s, it is a bit more of a challenge, and particularly with Tower Hamlets, City and Hackney and Newham. But that is just partly, it's a feature of health inequalities per se, and we know that those people that experience health inequalities more generally seem to be the ones that have been less able or less willing to come forward. That's why we need to do much more of this local targeting. Absolutely working with our local boroughs to encourage these people in and working through community groups. So we are, I mean, these are higher numbers than we've ever done for any other health intervention, but yes, we are a bit challenged in those areas compared to the rest of the country. But all of London has significant issues, particularly inner London and Westminster and around there, and Kensington, Chelsea, and Hammersmith and Fulham have also got particular challenges. So we're the area that we're being looked at when we look at the London and the national data, but there's an awful lot happening. One of the things, for example, we've been doing is encouraging whole households to come in, and we started that even before we were able to go down the age ranges as much. That was really successful. We did a pilot of that nationally in Newham, was really successful, particularly in bringing in people from Black African and Black Caribbean communities who came in as whole families, and we've been extending that across, and that's been really useful in terms of getting our numbers up in those cohorts. In terms of asylum seekers, yes, we've done quite a lot of work with trying to encourage asylum seekers in as well. If there's more we could do, because clearly the message doesn't appear to be completely out there that you don't have to have all your registration cards to get done, then I'm sure we can do it. And I'm very happy to work with borough teams on that. But we have been trying and targeting some events that way, in the same way that we did with, in the same sort of way we did with homeless people. And we are looking to do more local drives, and also this London campaign that is being launched, I think, at an event on Friday in Stratford will be quite helpful too, because that'll help target us. I wasn't sure I quite picked up the point on COVID antibodies.
It was antibodies, I suppose. Do you get the ONS data? for our area, which would be, I guess, the only way to tell her, wouldn't it?
Yeah, we don't get it broken down by our area, but it's something that I'm certainly very interested in. When we looked at our staff numbers, when we did back in June and July 2020, we did have a surprisingly high level of COVID antibodies in terms of our staff in our local NHS hospitals and GP surgeries. In some trusts, it was well over 26%, I remember. So, yeah, I'm sure that there will be a reasonably high level of antibodies. That data, of course, now needs to be looked at in the context of people who are vaccinated will also have a level of antibodies. So I am looking into trying to see whether we can get a local cut of that, but I think we need to be cautious as to what it might tell us.
Okay. Thank you, Simon. Thanks for all the hard work everyone's doing. We're all very grateful.
And thank you for your support in local government as well. It's been fantastic.
Thank you. Okay, I'm going to bring this, we've run over slightly there, so I'm going to bring this item to a close so we have enough time for our last substantive item. So last substantive item is number 6. This is to do with managing future changes of ownership of GP practices. It came out of the Oprose group taking over AT Medics, and that's a number of practices within the North East London footprint, and there was concern that had happened, but also as to the process about it happening via chair's action and the perceived lack of consultation. So this was our first meeting since both the December, I think, initial decision, then the February follow-up decision. So it's our first time to properly look at this. What we've got several members from North East London NHS, Henry, William, who's the Director of Primary Care Transformation, Selina, and Mary Price is the Director of Corporate Affairs. And then we've also got some of the concerned doctors, Jackie Appleby, Chair of Tower Hamlets LMC, and Dr. Gary Marlowe from City and Hackney LMC. So the way I'd like to structure it is maybe 5 to 7 minutes for those on the NHS, similar to maybe Jackie and Gary, to sort of ventilate their concerns with it, and then open it up to questions if we can do it in that way, so we can sort of hear both perspectives before we go. So from NHS side, who wants to? Henry, do you want to?
Yeah, I'll do what I've done before and give a brief introduction, and then I'll hand over to William. So thank you, Chair, for asking us to bring this item. So if I just start with, by way of a bit of context, and then hand over to William. So for the benefit of the committee, around 15 years ago, national government policy was to expand the capacity within primary care, and the way of doing that was to introduce new contracting mechanisms that enabled private providers to bid for contracts, and it enabled PCTs, as was then, to let those contracts to broader providers other than what we had before, which was predominantly GP practices operating under what was known as a GMS contract, so General Medical Services. So that government brought in something called an APMS contract, which was an alternative provider of medical services. That meant that you didn't have to be a registered practitioner to hold a contract. Other companies that employed registered practitioners to deliver the services could hold a contract. What this meant was it enabled the market to be expanded, and for primary care to have for private companies to bid for contracts and to provide primary care services. So that was at a time when we had a very different kind of ideology of competition and expansion, rather than what we have now, which is much more about collaboration. But it does mean that that's the context in which organisations such as AT Medics, who are a very good provider of primary care services, and essentially ended up having contracts. Within the contractual and legal considerations, like any private company, a company can be bought and sold. The company itself cannot transfer its contract from itself to another company, but the company can be bought in its entirety in the way that any corporate entity can be bought or sold. So essentially what has happened in this instance is that Operose has bought AT Medics lock, stock and barrel. AT Medics continues to be the holder of the contract, but they now have a parent company, Operose, who they have sold their shares to effectively. This is allowed under the legislation that was introduced 15 years ago, and is allowed under the contract. And so that's essentially the context. So in terms of the precise details, I'll hand over to William for just to kind of fill in the blanks a little bit about what happened over the course of the process, and then we'll pass back.
Thanks. Over to you, William. William, if you can, if I just ask you now, if you can sort of fill in the sort of the challenge about the process and the accountability, and it was done via chair's action, because I think that's generated some concern in and of itself. Oh, William, we've got you on mute. Still on mute.
How about that?
Perfect. Got you.
Apologies for that. So just to pick up on Henry's point, just to thank you for that, Henry, and thank you, Ben, for introducing me. So William Cullen-Davis, Director of Primary Care Transformation. So I'm here on behalf of Alison Goodlad, who's obviously runs the contracting team in NEL, the NHS England team. So just to remind the committee that all general practice are private practitioners. Ultimately, they all hold an NHS contract, so ultimately could be deemed to be all holding private companies. But obviously AT Medics and other companies obviously are allowed to hold more than one contract, and they have that kind of corporate kind of organizational setup. So what happened across London? So again, as I've previously come from Southwest London, so we had exactly the same system and the same process enacted within Southwest London CCG. We had 5 contracts, and certainly the same process of checking and validating and scrutinizing the request from AT Medics. As Henry said, they asked from point of view of change of ownership of the parent company, so the shareholdership of AT Medics and its contracts. And actually under the contractual framework that we all have to work to as part of the NHS England contracts, that was allowable. But certainly we added in extra steps of due diligence. So again, making sure around putting assurances in place to ensure that AT Medics would still be holding those contracts, that there wouldn't be change in personnel against the contract holders, so staffing, etc., but also that the actual current directors or the old directors of AT Medics would continue on that contract. So rather than each individual 5 STP taking separate legal advice, we all adopted a view of actually taking one advice to reduce the reduce the taxpayer's burden, because ultimately the same legal advice should be exactly the same for all of the STPs. I'm glad people are laughing, but that's true. That's what we chose, and obviously that from point of view of that's kind of what we arrived at from point of view of that. So South East London did it on behalf of. We obviously all took our own scrutiny of that, and obviously able to ask our own questions pertinent to our own contracts. But again, as within the contract, it was allowed to be novated across from that point of view. Legally, and actually all the various DMBs and the searches that were undertaken from point of view of due diligence on Operose and their various companies, again, it didn't turn up anything that we could find that would stop us under the current legislation to allow this not to occur. I think from point of view of Councillor Hay, that was really around the timing from point of view of how it was done. I think COVID, unfortunately, was a key player in all of this, where actually the normal primary care committees weren't meeting as frequently. And unfortunately, just trying to get the business as usual done. I think it was done on chair's action, again on the ask of of AT Medics. We did push back because they wanted it a lot sooner than December, but ultimately from point of view of the regulations and the ability for us to block it or stop it, that wasn't within our gift. So actually that was taken as chair's action from point of view of allowing this to happen, and that again happened similarly across the 5 patches within, or the 5 STPs in London. So with that, I'm probably done. Again, happy to have any questions.
Thanks, William. That's very helpful and concise. So now can I go to, if I go to maybe Jackie first, then I bring in Gary, if that's okay? Jackie, could you give your observations from your perspective, please?
Thank you very much for having us, and hi to William and Henry. Greatest respect to both of you. Okay, I mean, we are where we are with APMS contracts, but I would like to remind everybody that in Tower Hamlets, Atos ran an APMS contract, I think from about 2007. What alternative provider of medical services contract means is what it says on the tin. Anyone can run it. So Atos, I think, is an IT firm based in France. I don't know what you know, they don't know what what's the word I'm looking for, any experience they had of general practice. Anyway, they had to hand the contract back within 3 years because they couldn't perform. So just to really respond to a few things that have been said. So I'm just wondering where the patients were in all of this. I mean, this was done under Chair's action. We've been outside surgeries, we've been campaigning because we're very worried about sort of the influx of Centene, which is one of the biggest American health insurance companies, into general practice in London, and Operose is a subsidiary of Centene. None of the patients seem to know what was happening, and when we've talked to patients, they are all horrified. They don't want this sort of thing going on in their general practice. I can't believe that the CCG didn't know that this would be controversial. I know that we're in COVID and we've needed emergency powers in COVID, but what was so important that it had to be rushed through under Chair's action? But because your paper says, because that's what AT Medics asked for, because for commercial reasons. Well, for commercial reasons, for AT Medics doesn't really strike me as being something that is important under COVID legislation. Also, Centene have a terrible reputation, awful reputation, and Operose, their financial records are not great. So what happens if they go bust and Centene don't bail them out? Then what happens to the patients of these practices that have been taken over? And I really, really, really must take issue with this business about all GPs being private. We're not. We're subcontracted to the NHS. I mean, the practice I work in does not have shareholders to which we have to pay dividends every year. Any profit that's made is we're under a fixed contract with the NHS from the Treasury to provide services. Profit, in inverted commas, in general practice, certainly under GMS contracts, which is the most usual contract, is just a little bit extra to pay the partners. It's like a salary. It's not paying dividends to shareholders. So we're not worrying about what the shareholders are going to say, and we're not worrying about cutting costs, which is usually staff costs and services under these other providers. We're not worried about having to do that to pay shareholders. So there we go. So the due diligence, the day after the AT Medics was sold for many millions of pounds, allegedly, all of the AT Medics directors resigned, and so the 3 directors of Operose were left as directors of this, so that it isn't carrying on with the same personnel. They're no longer directors. And then Samantha Jones, she left as well and went, and now she's working for Number 10. So this whole thing, I mean, it's just a car crash, really. I think I need to leave some time for Gary to speak.
Thank you.
To go all over the coals, but I think this has been very, very shoddily done. Thank you.
Thank you, Jackie. Now, can I then go to Gary to finish off before we go open to questions? Gary?
Yeah, I'll be quite brief because I think Jackie said quite a lot of what I was going to say anyway. Just to correct you, I'm not on the Hackney LMC. I'm speaking as a recent past chair of the London Regional Council of the BMA, as a GP, obviously. Those of you who know me. Just to reiterate the point, it's an old canard to come up with GPs are private contractors, therefore it's fine. It is really chalk and cheese. So please don't keep repeating that as a part of the argument, or not the argument, but the explanation. One of the things that I'm particularly concerned about is that you talk about the legal opinion and legal advice, but I don't think the full legal advice was shared across all the different ICSs, and I think it would have been useful for the primary care committees to have seen the full legal advice. Maybe I'm wrong and it was fully shared, but I'm speaking to some people who are part of the primary care committee. I don't believe that it was fully shared, and that legal advice was open and available to anyone who wished to look at it. One of the other issues, just quickly, as I said, Jackie's covered quite a lot of this, is that I think there's a different people, and one of the sort of explanations is given is that this was legally allowable. I think just because it's legally allowable doesn't mean it was the right thing to do, and that there are options, and there were other options which we're not given a chance. The committees were not given a chance to explore. One of those would have been to novate it over, but to look at the length of the contract that was novated over. So you could have had a contract that was given to Operos for a year and then reviewed. So there were other options that I don't think were given adequate chance to be assessed and looked at in any detail. It seemed to be something that was done very quickly and was done almost on the nod. And the other thing is that one of the things that is often said, and I'm not sure if this is entirely true, is that APMS contracts are the only options that we have now for GP practices. And this is often repeated by many people. And I can't find anything that actually says that that is actually true. There are other options as far as I'm aware, but we are allowed to give contracts for GMS as well, unless I'm completely wrong. And if APMS contracts are the only options going forward, then I would like to see where that is, where that comes from, and who says it. But I think that's something that's again an old canard that's often circulated. We could go on for ages, but one of the worries, the big worries about this, is that it creates a group who, in essence, are driven, not driven necessarily, but are dominated by profit margins and shareholders, and that therefore the way to make the biggest profit in general practice is to have the cheapest staff you can to provide the care. So that means that you have more allied professionals providing healthcare, and maybe that is what we want to do in the NHS. Maybe that is the way primary care is going to go. But I think that at least patients should have the option of saying that they're happy with having allied professionals providing the care, and there being their first contact at every opportunity, and not being able to see GPs doctors as they wish.
Thanks, Gary. I think I hope I gave both sides about 6 or 7 minutes there for equity. I've got questions now. Cllr Masters.
Firstly, I'd just like to say I support everything that Jackie and Gary have said. During that period of the pandemic, as councillors, we were still all meeting virtually. There's no problem there. I'd like to thank AT Medics, who spent a lot of time sort of talking to me about their side of this, and I fully understand the fact that they may not want to deliver backroom services and sort of engage in bureaucracy. I think what I would like is a reassurance from our integrated care system colleagues that given that Operos have guaranteed not to be involved in the clinical side of this, and that side will still be delivered by AT Medics, that we're not going to see them sort of appearing on the partnership boards of our integrated care systems going forward, which I think would be incredibly worrying.
Okay, Councillor Snell.
Sorry, you caught me by surprise there. A very good question, and clearly Councillor Masters has got involved more than I've been able to do. But in terms of the lobbying that has come my way, the concern has been about the degree of GP practitioner control over these new contracts. So I just want to come straight back to William there and say, when you pass these original practices through AT Medics, you said, yeah, we made a lot of effort to make sure that the medics were in charge of it, that this wasn't dumbing down of the service. But does that mean that in their new format, now they've been bought out, when these contracts come up again, you're going to be turning around to them and saying, hey guys, can you still guarantee the same level of GP management of the delivery of services, or have we somehow lost control of that? And if so, why have we lost control of it? Can we go back to the MS contract instead of using the APMS contracts? I hope I've understood all that.
Okay, thank you. And then if I could just, I've got Councillor Hudson.
Thank you, Chair. This is a matter which has concerned other members of the Scrutiny Committee, and just to make it clear, I'm the City of London. We operate on a non-party political basis, so this is not a party political point at all, but there was a lot of concern about it amongst the other members of the City of London Social Care Scrutiny Committee. One of the aspects is that if we're going to have a commercial operation, a commercial organisation operating these GP practices, then the healthcare facilities provided and built by and paid for by the NHS ought to be charging a commercial rent rather than a reduced rent on those properties. So that, the reduced rent doesn't just go into shareholders' pockets. But the other thing I want to follow up on, two aspects, is one is on the legal advice. I think the full legal advice should be available to members. I never accept the comment that you won't understand it, because as a lawyer I do understand it, and sometimes I have been through very lengthy council contracts to take up points that quite simply officers didn't understand. But the other aspect is it is very simple to put in a corporate contract a change of control provision, which enables you to terminate the contract if there is a change of control. Now, if that is not allowed by law, I think we want to know that, because it may be that this committee will be recommending that we should take this up at a political level and lobby our members of parliament to try and get the law changed on this.
Okay, so we've got 4 questions. I've got Councillor Chowdjury. Can I answer? I've got enough time to come back for a second round, so I'll go for those. I'll go for those questions if I can first. William, do you want to start going through? I may have you on mute again, William.
Sorry, I will get there. Apologies. If I can just, so I think from point of view of so again, I suppose to play to Councillor Masters' point around there isn't, as my understanding, there isn't a requirement or from point of view of AT Medics or any corporate organisation per se sitting on a partnership board. And I know Henry you might want to chip in on that. But again, I think that's more around how we make the primary care representative in each of the boroughs, and that process is still to be worked through. But I'm not aware that there's a requirement or that actually that you would expect or not expect a practice or a corporate organisation to be on the partnership board. From point of view of Councillor Snell around the letting of GP contracts from point of view of APMS. So obviously there is a set format that we have to follow on based on NHS England guidance from point of view of contracts. So there is a procurement basis that we have to follow. And again, with the greatest respect to Dr. Marlowe, that is, as far as we're concerned and NHS England is concerned, and that is the only route of being able to offer new contracts. They have to go out formally onto OJET. They have to be advertised. There is a formal, robust procurement process that is independent. We have independent GPs on it. We have independent nurses, HR, finance that all review all of the bids. And that summarises the kind of procurement process, which is then let for a 5 to 10 year period. Obviously, that contractual period is once it comes to the end of 10 years, it has to go out to market. You can't roll it over. It has to be tested for the market, ideally. Obviously, if there are mitigating circumstances, then it can be rolled over for a further 12 months if you are starting your procurement activity. But from point of view of the process, we make sure that when we're coming up to certainly 12 months before the contract expiry, that actually we start putting the machinery in place to let those contracts. For Councillor Hudson, just around the rental aspect of the sites. So the way the mechanism works for primary care around primary care estate, whether it be GP owned premise or a commercial organisation or anything. We use the district valuer who deems the value for money on those properties. Now, that money doesn't go to the shareholders. It goes directly to the landlord or the owner of the building, which could be a GP. But ultimately, is that funding or that money goes, it is a pass-through. So whatever the, ultimately is, if the district value agrees £100, then we either pay the practice or the provider the same amount of money. So there isn't any profit to be had on that rental, if that was kind of behind the question. And I know you said 4 questions, Councillor Hayward.
I think Councillor Hudson was asking also about the legal advice and the extent to which that could be shared.
So the legal advice, I mean, again, is so just again is, and Henry, I might want to call on you, but from point of view of the legal advice was taken on a London basis. I think that it is commercially sensitive. I think it's for the party from point of view of the NHS. Again, I'm not aware that there were redacted or changed legal reports that weren't sent to PCCs. And I know, again, as the committee will know, that obviously that there are other areas within London that are looking to take legal action against what has been done. So I do think how much that can be shared, I'm not sure. Or kind of Henry, I don't know whether that.
Right, okay, well, I've got other questions coming in, and then maybe if it's okay, Henry can then wrap up with other points at the end, just to try and keep the flow here. Sure. So I've seen Councillor Chowdjury first, please.
Thank you, Chair. So during lockdown, I think I have spoken to more elderly people and vulnerable people more than ever. And what I have understood that it is really difficult to get in touch with their GP, especially if they don't know how to use online services. Sometimes people just give up, but I'm talking about lockdown, but slowly things are getting normal. But due to the new changes, always change can be positive, but then again, are we taking all these issues into consideration? Or my main concern is about the standard of services or quality of services. What are we going to be doing to make sure that it's not compromised? And if there are complaints or issues about practices, how is it going to be addressed?
Okay, thank you. And Councillor Salva McCallum.
I think mine's just really to go back to the procurement issue of if all the procurement processes were followed through, how we ended up with the chair's ruling in kind of December 2020, because there seems to be slight contradiction there. And also regarding the legal advice, whether or not it can be shared with the committee, there does seem to be a lot of discussion around this change of control decision, and whether or not some of that also could be shared with the committee so that we could fully evaluate and scrutinise that.
Okay. William, do you want to come back on those points first?
So if I come back just around the lockdown and kind of access to primary care. So obviously be aware NHS England mandated a total triage for general practice. So obviously close the doors and obviously go online and on telephone. So it wasn't just online and computers. So people should have been able to get through on telephones or certainly get a call back. Obviously we are starting to return to business as usual. Again, general practice at the moment is inundated with and I'm sure Jackie will chip in from point of view of the amount of patients contacting them. Again, we're working through online, telephone and video consultations, and actually trying to work through to get back to the new normal. So obviously it allows patients to walk in and book appointments, but also to see doctors as required face to face. So I think we are starting to get back to more normal. From point of view of where we have patient complaints, so I meet with certainly the Health Watch locally, but also get patient complaints directly from NHS England and the complaints team. So we obviously pick those up directly with practices and with patients. And where we have issues or areas where there are concern, we will go and see those practices and go and visit those, to understand what the issues are and unlock that, and to make sure that service is still continuing and it's good quality. Councillor McCallum, from point of view, I missed a bit about the procurement process. So the current procurement process was undertaken over 6-7 years ago. We're talking about the new current process from point of view of there is a set process that we have to use. Again, I'll defer to Henry just on the legal advice of where we're at with that. So just the procurement. If we could just regroup on that procurement.
I think the point was how can the procurement process just go through chair's action without any?
So it was so to be clear for the record, it wasn't a procurement process. This was a change of ownership, which is allowable under the contract. So we didn't rerun a procurement process. What I was talking about is when, as one of your, I think it was Councillor Snell was saying, what happens when the 10 years is up? What happens? Can we just go back to AT Medics or APROs and say, can you carry on doing it? There's a formal process that says no. You need to go back out to a formal procurement process as we did at the start of this process.
But can I just say, going forward, to say there's a similar request for a takeover during the middle of a third wave when our acute hospitals are busy again. Have we now in a position where this will not, if that's a similar situation, we won't be going through chair's action? This will because from what I'm seeing, you've almost made it worse for yourselves through not ventilating this in the first place, and then it's backfired.
I've only been in the area for 8 weeks.
It wasn't a personal criticism. It was a generic.
No, agree. So I think that's right. I think actually we should have held more PCCs in public. Again, because we were so focused on getting COVID sorted, we took our eye off the ball in that respect. I think from point of view of changing the decision, I don't think it would have changed the decision, because I think that was the decision that we could only make, and that was the only decision that we unfortunately could make.
And what do you say to Dr. Marlowe's point about why you didn't go for a shorter novation agreement to see it for a shorter period of time? Was that possible?
Well, we had a contracts that are in place for a set pace of time. You wouldn't renegotiate every contract from point of view of it's the change of the parent company rather than AT Medics itself.
But you're saying that option wasn't available to you?
No.
And what about putting into future contractual procurement rules about the need to be a local link with the neighbourhood and making that more of an emphasis for ongoing procurement or change of ownership? Have you got that available to you?
So we certainly, from point of view of we've been working with Jackie, certainly we're on the Tower Hamlets kind of worry list around how do we make sure that we have very, very much focused local questions when we're in procurement, but we can't favour any provider, whether it be local, national, whatever. We need to be open and transparent with that procurement process. But what we can do, and we are going to do, is engage locally with stakeholders and ensure questions are local and very pertinent, so that it increases the localness and the kind of answers and the assurance that actually they are a local provider, or certainly understand the local area and are able to deliver high quality services for the same price as anybody else.
And just before, Councillor Hudson would like to come back in, and just one further question if I can. Say the parent company taking over has, say, that they are, say, a US company. I'm using a hypothetical example here, but say there have been corporate charges against that US company. Is that something you can take into account on due diligence? Hypothetically, I'm not making any accusations about any company, but say a future US parent company with corporate charges of fraud against them, why can't you take that into account on due diligence?
So it depends how deep so if you look at the layers that are sitting within it, is around where does that where does it stop? Because you could go back and back. Again, I don't have a definitive yes or no answer for you today.
Okay. Councillor Hudson?
Yes, thank you, Chair. I want to challenge the officer's answer to the question about local providers. Why can't you make it one of your terms in your procurement criteria that you will give a percentage points to local providers? I regularly see this in other contracts. You get it for apprentices, you get it for various things on quality. Why can't you put a local basin as part of your criteria when awarding the contract?
Okay, I've also got, just before you come back, because we're running out of time, so I've got Councillor Snell, I think. Is that a new question, Councillor Snell? Or an old one? No, it's an old one. So this is the last round because I'm going to wrap up. No, so Councillor Hudson, and then we're going to wrap up. So answer that one if you can, please, William.
Because that would be wouldn't be transparent and fair. It would actually, you just can't run that, and actually that is an NHS England process.
Okay, so you're saying that's not possible. Go on, William.
No, fine.
Right, I've got Mark Ricketts who's raised his hand. Mark, do you want to come in briefly? I will quickly come back to Henry because I said I would.
It's just that those individual practices with whom the individual APMS contracts are with are often very embedded in their local communities, actually, and just like any other practice. Interestingly, although those partners who had shares in the ownership company under their APMS arrangements, they left that. As far as I know, they're all still working in their practices. We haven't had a slew of complaints about the services being downgraded in any way yet, and certainly there's a lot of kind of keeping an eye on that, actually, just in case. So we're not seeing that. They're managed like any other practice. So it's important that actually, as far as the interface with patients are concerned, that seems to be okay. Sitting behind all that is the issue about how this came to be in terms of the change of ownership of the owning organisation. And of course, there are further reviews ongoing into all the details of that, and they will run their course, and we shall learn from that what's revealed. But I guess tonight, as far as William says, there was nothing much else that could be done with the guidance we had under contract law at the time in December. So whether those meetings were all in public or not, I think your point is well made about if we'd ventilated the issues more then, it would have saved a lot of the kind of worry that what's gone on here. But I'm not sure it would have changed the decision, because the decision was legally, kind of determined as far as our legal advice was. I mean, we may not like that, but that's where we were with it. And as I say, the further review of it all is ongoing, isn't it? And the judicial review in all central London. So we'll see what that turns up.
Thanks, Mark. Henry, do you very quickly want to respond to anything?
I'll do my best.
In 1 minute, if you can.
Very quickly. So I'll just try and pick up a number of things, and you can stop me when I've run out of time. But firstly, in terms of Operos being part of any future partnership board, I can give you my assurance that won't happen. Operos are not a provider of services within the ICS. They own 80 medics who are a provider, but Operos would not be part of a partnership board. So I can absolutely say that. As Mark says, there is an ongoing legal case that's still being worked through in North Central London. So in terms of the legal advice, we would not be able to share that at this point in time. We might be able to review that in future once that legal case is concluded, but we wouldn't be able to do that now. I suppose just more broadly, the reason that we have the APMS contracts and the reason we have other providers other than local GMS practices is because we are required to commission the highest possible quality services that we can, and in the case of contracts that we've had to resort to this, it's been because we have had quality failings in the past, and in fact 80 medics in particular have done a really good job of coming in and providing a high quality service. So it does need to be recognised that they have actually plugged a gap in the market in many ways. But I think more broadly, from a strategic perspective, we, as an ICS and in North East London, we have got a long track record of supporting primary care, and it is one of my personal kind of priorities is to ensure that local primary care is of the highest quality possible, so that if we ever have these situations again, a local practice will be in a position to bid successfully for that contract. That's what I want to happen, and we will continue to work with primary care to try and support and develop that functionality and that ability, so that in the future that is, you know, our primary care practices are in the best possible position to do that.
Thank you, Henry. So I think I've got an understanding that if we're in a similar situation in the future, we're not going via chair's action.
Not chair's action. We will ensure that there is a public meeting. Yeah.
Okay, right. Thank you. With that, we're 4 minutes over, so I'm going to wrap up that item. Thank you, everyone who came and contributed towards that. Thank you, Jackie. Thank you, Gary, for coming as well. Minutes of the previous meeting. Can I take those as read, please, members? Thank you. The work programme is at the back of the agenda. Next meeting on the 13th of September. Any sort of ideas? I mean, some things have sort of come out of tonight. Please email myself and Jarlath, and we'll take that forward. I haven't been notified of any other business. So with that, Councillor Hudson.
Yes, Chair. I wanted to follow up on 2 items. First of all, item 6. We certainly regularly get non-public papers, and I wonder whether we as a committee should ask for the legal advice to be provided on a non-public basis. And also, do we as a committee want to resolve to lobby all members of Parliament, including the Member of Parliament for the City of London, Westminster, on a change in the rules, procurement rules, to enable a change of control of the provider to be a trigger point at which the contract can be terminated. There's been quite a lot of discussion about this evening, but I would certainly be supportive of both those.
Well, I mean, that could be certainly something that we could discuss amongst ourselves, possibly online. I'm not sure you're going to get much opposition towards that, looking around the room on the latter point, but certainly something we could pick that up amongst ourselves and possibly consider moving forward. On a personal level, I'd certainly be happy to support the latter one. On the first one, it seems to be clear that there is this legal case ongoing at the moment, and it may be that
with respect to that, we regularly in the city have this, and we have members of the authority who will challenge the legal advice given. We are in this mission, admittedly, being the city, where we have QCs amongst our members who will challenge, who actually challenge us, and we have litigation going on, sometimes going up to the Supreme Court. So we are dealing with things, but this is all dealt with in non-public business, and obviously this is non-public, and we have to understand that if we are provided with an opinion, it should be non-public. But anyway,
I think maybe what we can do is we can put that. We can. I mean, there is a part of sort of the public accountability aspects about not being in public with that, but I think, can we make that? I've got no problem with making that request to colleagues and to see how they respond to it, and then we can take it from there as appropriate. But then obviously it possibly puts us as elected representatives in difficult position as to how we then handle that, but that's maybe something we can cross that bridge.
Well, maybe you don't have so much non-public business as we do in the city, Chair.
With that, so we can take those forward offline, and then publish any action we take as a result of that. So thank you for those, and with that, 7 minutes over time, I will close the meeting. Thank you, everybody.
Thank you.